Welcome, Professor Mukherjee. Professor Mukherjee is one of Sydney's leading adult and paediatric ear, nose and throat surgeons with special skills in advanced ear surgery. Following her ENT training in Sydney, she attained further subspecialty post-fellowship training in otology, cochlear implantation and lateral skull-based surgery at Oxford and London. As well as treating general ENT diseases, her areas of expertise include hearing and balance disorders such as Menieres Disease, otosclerosis, vestibular schwannoma, cochlear implantation, and chronic ear diseases. She's also trained in middle ear endoscopy. She's a clinical associate professor of surgery at the University of Sydney and an adjunct professor at the University of Wollongong. She is the ENT lead for research at the RPA Institute of Academic Surgery and a committee member of the section for academic surgery of the Royal Australasian College of Surgeons. She is also a committee member of the Menieres Research Fund at the University of Sydney. She's been awarded several research grants as chief investigator and is currently completing a PhD in personalised medicine and 3D technologies in ENT. She is passionate about global translation and Australian innovation in biotechnology. Professor Mukherjee places particular importance on research and teaching and practices both as a teacher and educator at the Sydney Adventist Hospital and RPA Hospital. As a leader, she embraces thinking outside the square and driving cultural change. As a mother to a young daughter, she is very passionate about education and literacy development in young children. She is committed to mentoring children and junior doctors, especially females, into pursuing STEM careers in surgery and medical technology. For this work, she was selected as a finalist for the New South Wales Premier Women of the Year 2019. Welcome, Professor Mukherjee.
Thanks, Anita. That's a very long bio. I must ask the girls to send you a shorter one and a more recent one. But I'd just like to comment that I know that some of you are aware that a lot of our Menieres research is also starting up new at Macquarie. And so just to let you know that that's happening as well. So just with that, thank you very much for inviting me. And it is late in the evening, so I really wanted this to be a very informal type platform. So please feel free to ask any questions. Sarah sent me some common questions that come across her way, and I literally just took those questions and I've used that quite deliberately as the starting points of my slides, and so that's why I sort of said that I'm really very keen not to make this kind of like a didactic talk like a clinician would normally do it, but really very patient focused and question focused talk. So Menieres disease, as you know, it is a dynamic disease. Most of you who have experienced it, it's a disease involving the inner ear. This is a video that one of my students made as part of his University of Sydney project, which sort of shows how high drops occurs in the inner ear in the endolymphatic chamber, and it usually sort of starts in the cochlear region where endolymph is made, and typically, if it's in its most simplest form, if it's unable to drain appropriately through the endolymphatic sac and endolymphatic duct and sac, it will reflux into the vestibular system, which often patients get vestibular symptoms. And so often, because this is changing, patients' symptoms change depending on where the high drops is, whether there is high drops at the time or where the high drops is. So if it's in the cochlear section, patients often develop in the early phase low frequency hearing loss, fullness, tinnitus. But if it's in the vestibular system, depending on what part of the vestibular system is, they may develop severe vertigo, a little bit of vertigo, or just unsteadiness. And so because of this, the presentation of Menieres is highly variable, and therefore sometimes diagnosis is highly variable. But despite all of this, sorry, I was meant to change that to 20, actually that is right, 2015. Because of all of this, the most recent diagnostic criteria that was revised in 2015 was is still a clinically based criteria for Menieres. Even though we do have tests that help support it, often you'll find most of your clinicians will really spend a lot of time on the history, because it's in the history that the diagnosis is made. But for clinical diagnosis, you also need, as per the criteria, an audiogram. So that's the basic of what you need. But of course, there are many more tools up our sleeves that help us navigate whether a patient is experiencing Menieres, a Menieres attack, which I'll expand on later. So if a patient's had more than two or more episodes of vertigo that last 20 minutes to 12 hours, history of fluctuating oral symptoms, not better accounted by another vestibular disease, and ideally documented hearing loss. Typically, the hearing loss is low frequency, and especially if there's documentation of fluctuating hearing loss, such as the hearing loss was low frequency hearing loss a few months later, when the patient's better, if the hearing loss is resolved, that's highly suggestive as well of Menieres disease, because there's very few conditions that may cause it. When we talked about other vestibular conditions, in the spectrum of both auditory and vestibular symptoms that Menieres patients experience, there is vestibular migraine, sometimes BPPV, sometimes cervicogenic vertigo, which is essentially vertigo that arises due to pathology in the neck, life stresses, and poor dietary control. Of course, these make Menieres worse, but there are other conditions that can also be exacerbated, other vestibular conditions that can also be exacerbated with life stresses. In terms of diagnosis, there are two, apart from the criteria, which is auditory testings or hearing test, there are other tests up our sleeves, and they include balance tests and also MRI scans. Now, most of the time, MRI scans are done to exclude a tumor. And it's routine. So most patients who present with repeated recurrent vertigo or asymmetric hearing loss, a hearing loss which is worse in one ear than the other, will get an MRI scan, and we do it routinely to exclude a tumor in the brain or the cochlear nerve or the balance nerve. However, there are tests that help pick, MRIs can be used to help pick high drops. And the reason I put this on here is because some of you may have seen it in the literature, but it's not routinely done in Sydney. We absolutely have the capacity to do it. It's just, it requires special radiological skills, but we do have the radiologists in Sydney to do it. It's just a matter of getting it started. And the reason I think this is more undertaken overseas rather than in Sydney is because of our history of being the world leading center of vestibular research. And therefore we have very highly evolved vestibular testing parameters that also pick up high drops. And so rather than give a patient contrast in an MRI scan in Sydney, the reliance has been more on vestibular testing to add to the monitoring and making sure that the patient is improving from Menieres disease. So I suppose, there's no, with that, there's no one cure for Menieres disease, and really because the symptoms are so variable across the whole spectrum of auditory and vestibular symptoms, the goal is to customize the cure for each patient depending on what that patient's trigger factors are. And just, before we go on into what those treatment strategies are, often I have patients sort of wondering, what vestibular migraines are, because often there's a lot of patients who have Menieres disease as well as vestibular migraines, and the same things that make Menieres worse, such as stress, can also make vestibular migraine worse. So I thought I'd just make put a little diagnostic criteria for vestibular migraine. And that's, at least 5 episodes of vestibular symptoms, which can last from 5 minutes to 72 hours. And you can see that, it's often these patients have a background history of having migraines. Sometimes they get different types of auras. They may or may not get auras as well, but they definitely, they at least have a history of having some sort of a migrainous variant, and then they can develop a vestibular specific migraine. Now, of course, vestibular migraine does not influence hearing loss, and that's why, that the importance of a hearing test. So if there is hearing fluctuation, you can be sure that that particular attack is not related to vestibular migraine. But in the journey of a Menieres patient whose Menieres is really well controlled, and they've had a past history of migraine, they can get vertigo, which is not responding to their usual Menieres treatment because they've developed vestibular migraine. So it's important to understand that these factors can play, and similar factors will trigger off both diseases. Now, again, these are images from in 2020. There was a large international body directed by the American Academy of Otolaryngology, which is ENT, that set some clinical practice guidelines just to help look at. They just looked at all of the literature and looked at what there's evidence for and what there's not evidence for, and where there's a lot of variation in interpretation of results. They've then suggested gone with recommendations for the things that is consistent. So there's consistency across international guidelines in terms of what is thought as internationally okay to do, and what is doubt, where there's doubt and variation, and where probably there's not a lot of literature to support its ongoing use. So they looked at treatment aspects of Menieres. They looked at dietary restrictions, which is really common, medications, non-invasive, and then increasingly more invasive strategies. And even in the most basic thing that we use for Menieres disease, you'll see which is a low sodium diet, you'll see that there's actually no Menieres treatment guideline. The guidelines for salt reductions adapted from the American Heart Association guidelines. But in practice, we say that there's salt restriction, but again, in my practice, I modified that by measuring 24-hour urinary sodium test to see how low the salt is in the body, and I'll go through that in a sec. But of course, limiting alcohol and caffeine intake, and then adding medications and upping the intervention. I have a particular strategy in how I then apply those interventions. I break them into strategies of prevention, strategies of symptom control, so when there's an attack, and strategies of ablation when 1 and 2 has not worked. And of course, in between attacks, there's a strategy of recovery as well. So the thing that, and again, it's going from, absolute non-invasive to absolute invasive. And the most basic thing you try to do is a low salt diet. And often my patients come and say, look, I am on a low salt diet and it's still not effective, if it is not effective. And I think the only way to audit the diet is through a 24-hour urinary sodium test. So even though that's not, wasn't listed as part of the treatment strategies, I do use that in my armamentarium in a patient who's not responding to initial measures to make sure that we're monitoring their diet is effective or not. Lifestyle modifications play a huge role. I've seen a huge spike of Menieres presentation in COVID, in the stresses that, not COVID directly, but the stresses that COVID has presented, especially during the alpha wave when a lot of people in the community were losing jobs and people were having to let go. So I had patients who had not had attacks for 12, 13 years suddenly presenting with acute attacks, and then having, needing a little bit of support to get by. And of course, if 1 and 2 doesn't work, another strategy is modulatic. With respect to circ, I often say to my patients that there's not lot of high level proof that circ definitely works. It's not a high risk medication. Some people really find it effective, and some people don't find it effective. So I have a very low threshold for trying circ and then weaning it off if it's not having a role. Endolymphatic sac surgery, again, it's a non-ablative strategy for prevention, and I would only then do that if the patient has good hearing, they're not suitable for an ablative strategy, and the other factors haven't really been effective. I've put the antioxidants up there because I've had a lot of questions recently from patients about SPI 1005. Antioxidants have been trialed in Menieres disease for a long time. There's the general consensus is that it is probably effective, but it's not one of the recommended guidelines. This particular agent, SPI, is currently under clinical trials in the US. There's no clinical trials in Australia. And the data on that, although there's sort of some early signs that it's probably effective, the phase 3 trials have not been completed. And it's actually not TGA approved in Australia for use in Menieres disease, which is why it's a bit difficult to prescribe that for patients. But I'm hopeful that, once the trials overseas have been completed and we have some data, that should not be too far away. And then I give patients, patients will have attacks from time to time, depending on relapse with diet or a stressful situation. So I always give them an attack pack for their symptom control. And if they're needing to use their attack pack frequently, that's then a cause to stop and consider ablative therapies. And typically, that would be when, sorry, I forgot to list intratympanic steroids here as well. So what I would do is typically if somebody was not responding, then I would try a non-ablative strategy such as intratympanic steroids, usually in patients who have good hearing. But if the patient has poor hearing, then there's, very little to preserve. And then you look at, looking at ablating the vestibular system, which is what Menieres is trying to do, but the ablative strategies just accelerates the process. And so intratympanic gentamicin is just in the office is relatively non-invasive strategy. But of course, if that hasn't worked, then labyrinthectomy. And these days, I'd always apply that with the cochlear implant because it gets the best of both worlds, kills off the vestibular system, but regenerates the hearing at the same time. Well, not regenerate, it rehabilitates the hearing at the same time. And of course, vestibular nerve section is another strategy for patients who have terrible vertigo with very good hearing. However, it is probably one of the most invasive strategies of all of them because it's an intracranial procedure. And so it's not a common procedure that people do, especially now with cochlear implants being so readily available. And I mentioned vestibular physiotherapy, and you can't underestimate the impact of vestibular physiotherapy, whether it's after ablation or prehab before planning an ablative procedure, or just in between attacks to get the patient back to rehab them, because whether it's ablation or Menieres itself, it eventually will kill off the balance system. So the patients need to train their body and their brain to rehabilitate themselves. So the next question, Anne mentioned was, we're talking about the extreme of the vestibular symptoms, such as burnout or not burnout, sorry, drop attacks and burnout, and the extreme of hearing, what happens if the hearing goes. And I think it's you have this tug of war that you're playing with balancing the hearing loss, strategies for hearing loss versus balancing the vestibular complaints. And I think most patients who've suffered vestibular, bad vestibular attacks from Menieres disease will say, look, it's very clear I would sacrifice my hearing any day, if I got relief from my vertigo. But the reason it's not such an easy strategy for us as clinicians is this. The vestibular system has a lot of, not the vestibular system, sorry, the balance system has a lot of inputs in the body. There's two ears that are constantly talking to each other and talking to the brain, but the visual system also gives input to the brain about, where your sense of balance is, and the proprioceptive system, which is the joints and the muscles, is constantly sending input to the body, to the brain, and the brain's then collating all that data and telling the body where it needs to be. Now, if one of those systems dies, it means that you have a significant reserve in your other systems to be able to train yourself. But with a hearing system, if your right ear does not hear, that's it, your right ear doesn't hear. You only have the left ear, and the left ear and the right ear hearing system don't talk to each other. So you basically don't have any input from one side. And if the other system, the other ear developed problems down the track, either due to age-related hearing loss or Menieres in the other ear, that's it, you have no hearing. If worst case scenario, we could ablate the balance system, and rehabilitate through using the other pathways, you just can't do that for the hearing system. So it's really important to actively address both, and so it's and also therefore most clinicians you'll be finding would be hesitant to ablate the balance system, because usually the hearing system it's much easier to anything that you do to ablate the balance system will kill the hearing system as well. So in terms of the sequelae of the long-term sequelae of balance outcomes, we talked about drop attacks, and drop attacks are, I suppose, a dangerous dangerous sequelae of Menieres disease, where patients may suddenly fall. It usually occurs in the late stages of Menieres, and it's meant to be due to it's called the utricular crisis. So one part of the balance system just has, it gets overwhelmed, and the patients lose their sense of where they are, and they tend to fall. Now, obviously, sudden falls like that can also occur in a stroke, but very rarely. In a stroke, there's recovery of function. But in the setting of Menieres, having a sudden fall can really cause harm. So I certainly have seen patients who've had fractured arms and injured their head. And so because of that, and of course, if that happens, if a patient's driving, you can see that that's an absolute, I don't need to explain how dangerous that would be. So patients who have drop attacks, it's important that they don't ignore it. Clinicians usually will start to consider very actively ablative strategies. It doesn't mean that they require labyrinthectomy straight away, but at least gentamicin. And if the gentamicin has not been absorbed, it hasn't worked, then yes, most certainly they would, safety first, so they would definitely be transitioned to labyrinthectomy or other such or other ablative therapies like nerve section. Burnout is a great result of Menieres disease, and often it just means when the disease stabilizes. But in the interim, often the hearing and the balance, the vestibular functions deteriorated. So I'm just putting my skeptic, particularly through COVID, seeing lots of patients who have been enjoying a condition of stability and thinking they've burnt out, coming back with active Menieres disease is sort of, really makes me question whether burnout is just stability versus, loss of function. So, if you don't have a receptor, a balanced receptor that is able to send signals to the brain, even if you have active high drops, so, pressure building up in the inner ear, you may not actually be that unwell from it. And so it's hard to know whether burnout is just, I think there's no possibility of being sure whether burnout is just that the disease, your inner ear is just so damaged that it doesn't sense the Menieres anymore. You're resilient towards your symptoms, or it's the fact that you don't actually have active disease, and your ear's just not, misbehaving. And it may be because the trigger factors for Menieres has gone down. And then it really depends on what the trigger factors are. So it's hard to sort of say to a patient. I find the term burnout difficult because I find that, it sort of gives a sense of hope to the patient that I will never get it again. And often if, patients have not had symptoms for a while, you sort of think, look, it's great, but I can't often say for certainty, especially if they have good residual function, that, if they have a extremely stressful life circumstance, they're not going to get their symptoms back. So I always use that term with caution. As far as hearing sequelae, sorry, this video doesn't work because I'm playing this on a Mac and it's a PC-based video. But really, in terms of hearing, I find that the hearing outcomes are actually really straightforward to manage. And so I spend much more time managing the balance symptoms of my patients. Of course, there's hearing aids, and it's important to manage. It's important to treat the hearing alongside the balance, even though the balance might be more disabling. But in terms of options, there's hearing aids, and when hearing aids are no longer effective, there's cochlear implantation. Now, cochlear implantation technology has evolved, and the way we assess cochlear implant candidacy has evolved. In the past, used to be that you had to be profoundly deaf in both ears to consider cochlear implantation. But nowadays, we know if you have single-sided loss, meaning you have good hearing in one side, but poor hearing in the other, then we would absolutely consider cochlear implantation. And the other thing is also, sometimes people on an audiogram may have what seems to be good hearing, but with Menieres patients, I find that their speech understanding may be disproportionately poor, even though the audiogram looks not that bad. And so the way we would then assess patients whether they're suitable for cochlear implant is have patients have a hearing aid and have patients test their speech understanding. And that's, then you sort of give them a set of words and give them a set of sentences, and see that with the best aided hearing, as in, with wearing a hearing aid, what's the best understanding that they're getting from their hearing aid. And that's really important that that's not done when the patient's hearing is fluctuating. It's done when the patient's hearing is stable. So we can kind of be certain that we're catching them at a good time, and then we can start the conversation about cochlear implantation. I know that I think probably Salini and Bill are probably on this in this meeting.
No.
So they will recognize this study that we did in Sydney a few years ago, where we looked at the outcome of cochlear implantation in patients.
Well underway.
Bill, you might need to mute yourself. So what we saw actually, and these are patients preoperative scores, and these are patients postoperative scores. And we found that, patients with Menieres disease did really well with cochlear implantation. And I think that's because Menieres patients, unlike patients who've had, age-related hearing loss or other types of hearing loss, the reason for their hearing deterioration is often in the cochlea. So it's cell related, and cochlear implants, although they sit in the cochlea, they stimulate the cochlear nerve. So they often, Menieres patients often have a really healthy cochlear nerve. So their outcome of cochlear implantation is actually very good. And that's, why in my mind, like after doing that study, I really changed my strategy in how I manage my Menieres patients. I know that their hearing outcomes are going to be good. If hearing aids don't work, a cochlear implant is going to give them a really good result, provided they've managed to keep aiding themselves during this process. But it's really managing their balance symptoms that is a dicey business. And so I spend a lot of time making sure that we really addressed and got them to status quo with their balance symptoms prior to even, considering cochlear implantation. So I think the last thing that Selene had was talk about future research. I think, if you look at, there's a lot of research that's happening, across the world, and especially in New South Wales. And if we break up the research categories, as a lot of us don't really understand why Menieres disease occurs. So there's a lot of work that happens in developing animal models and having and understanding, putting theories of why it forms and what triggers it, and following them through. There's a lot of work that's happening in diagnostic strategies and better strategies and of diagnosing Menieres disease, and of course Menieres disease treatment. So in terms of understanding cause, and many of you may have had our scientists such as Mohsen and Chris Pastras and Daniel Brown, often on this platform, discuss a lot of their animal research. And it's really, really important, that body of work, to look at each of these hypotheses that we have about Menieres disease. And once we then see it in animals and we prove it, we can then translate that into human trials to see if then therapies targeted for those strategies work. It's not so easy, however, because animal models, the human inner ear is quite unique. For some reason, the human cochlea is extremely prone to damage, which is unlike, say, guinea pig cochlears or other small animal models that we have. And so it's not really easy to sort of say we've seen that in animals, so it will definitely work in a human. And one of the research strategies, for example, vestibular implants, that's happened across the world. I mean, one of the, really worked very well in monkeys, but when it was translated to humans in Menieres patients, the results were not so, there were some early challenges, and that really, was a hurdle. But I'm hoping that research is, not too far around the corner for our Menieres patients. So in terms of then looking at, diagnosis and treatment research, most of this is done, in clinical patients, because I think, as I said, because there are challenges with, the animal ears, we really don't know for certain if it's going to work in humans unless we try it on humans. And, really grateful to some of my patients who are probably on this platform today, who put their hand up quite readily to enroll in clinical trials. There's a lot of anatomy-based studies that I've been involved in, and some of them I've got images for. And a lot of the anatomy-based studies require cadaveric human bones to look at the anatomy, and then of course the treatment, the other diagnostic strategies and things like that are looking at, for example, we have viral study trials and things like that occurring, and it's just to study those cofactors in patients as well. So these are some of the studies that we have in terms of animal studies. This is on the left is a study that one of our students has just published about a narrowing between a very narrow duct between the cochlea and the balance organ. And this is another study on the right-hand side that another student's published, which looks at a narrowing between the saccule and the utricle, called the Bass valve. And these areas are opening up. We've never been able to image image these areas in 3D like we have now. And these areas are opening up a whole new level of understanding. And then we can match these up with the vestibular tests that we see in our patients to see, all right, well, what class of patients are, developing what class of symptoms, and then backtracking, the relevance of these areas. And then hopefully once, if, blockages or not rupture, but blockages of these areas help, there are, we are in the era of new technology, such as, targeted drug therapies and, nanoscience and nanotechnology, where we can work towards delivering specific treatments to these areas. This is not one of our studies, but I think it's a study that's really influenced my thinking, a study looking at the endolymphatic sac, and also sort of looking at how anatomy varies between patients to patients. And I think, sometimes my patients ask me, look, my parents had Menieres, or my father had Menieres disease, is this genetic? And I think there's no genetic link found to Menieres, but there are studies that show that some patients with Menieres disease have a narrowing of their endolymphatic duct anatomically, but there are patients who have hydrops but have not developed Menieres disease who also have this narrowing. So it sort of generates this thing to say, maybe some patients are predisposed to getting Menieres disease. So if you've got narrow anatomy and then you've got a bit of sludge or some immune mechanism triggering off a reaction in this area, you're more predisposed to having blockage of the endolymphatic sac, and therefore maybe you have more symptoms. So it's really, it's really good that these studies are being reported. And I think, really we're sort of, looking at, therefore, understanding tissues and getting more of more idea in terms of how the inner ear behaves. You would think that in any other disease process, this is, really basic. Like, you have lots of pathological data, and you can analyze tissue in normal and in disease and kind of go, well, this is what's happening in the disease, and therefore this is how we need to target therapy. But the inner ear is very unique because the inner ear tissue is so thin and fragile. It's very hard to even harvest the tissue. However, we have done a study for 3 years, where we did harvest tissue, and we had a look at, what it looked like in patients who didn't have Menieres. And in this setting, we can only do it in a labyrinthectomy, which is quite an invasive operation for the ear. So we harvested of patients who have acoustic neuroma, and we compared that to Menieres patients who were undergoing labyrinthectomy because of severe Menieres. So these patients had not, they actually had good vestibular function, but they were having quite active Menieres. What we noticed in both is that we thought, in the literature, there was sort of certain reports of abnormal vascularity or swelling of the connective tissues. But what we actually came back realizing is that the inner ear tissue is very unique, and there's a lot of the data. So this is actually a table that I made of the literature in terms of how many studies there are looking at inner ear tissue, and this is our study. And you will see that the data, is not often, you don't have a good control and a good test, so it's very difficult to control. Like, you've got 24 cadaveric Menieres patients, but no control. So it's very difficult to then make sure that you're making a scientific conclusion about whether your data is actually real, like it's a real abnormality, or it's just by chance. And so the fact that we had a huge amount of patients where we've got both disease and control data was amazing. What we found was that we didn't really see in these patients a lot of degeneration or connective tissue disease or vascular disease, but we do think that there is therefore more to be targeted with respect to endolymphatic sac. But the problem that we've had is we don't normally have to harvest endolymphatic sac. You can decompress it, but it's hard to design an experiment where you can harvest the endolymphatic sac of a Menieres patient. And so the numbers are extremely difficult to attain to actually study it. We can of course study it in cadavers, and I think once we get some more, we don't have a tissue bank of Menieres patients in Australia, but there is in America. So we're sort of looking to America at the moment to get some cadaveric Menieres tissue data. That sort of data is really, we sort of think, okay, well, that's good that you've got the data. What does that mean for the Menieres patients? So I think, that sort of data we're collecting of severe attacks, but the large proportion of patients who present, to me at least in the clinic, are patients with moderate disease. And I think the thing I find frustrating as a clinician is this group of patients actually difficult to study, because you don't need to take them to theatre, you can't get tissue. Their disease is variable. Some patients have majority, auditory disease, some patients have vestibular disease, and really your priority as a clinician is to settle their symptoms. So it's important to, I think in my research, I actually took a step back and thought, look, before we do that, let's turn to available technologies so we can get the data collection homogenized. And so a lot of you may have been exposed to a few of the trials in terms of data collection. So we've had, as I said before, in Sydney, we are actually experts in vestibular testing and vestibular data and novel data collection strategies in using vestibular rehab, in using virtual reality in rehab as well. And a lot of these help give us metrics of data, which you can then make it less subjective and more objective, and therefore make it easier to measure on patients. But the other aspect that I have started exploring is to actually look at, big data. So if you, particularly with the most common patients, which is in the moderate range, if you are gathering audiological data as well as vestibular data, what can we then put on a platform that, we can scale not just to the state, but nationally or even internationally in databases that helps us then kind of actually look at all of the variables. And that's why I turned to artificial intelligence as a tool, because it really is a technology geared to helping us understand disease that has numerous variables. And, something that as human beings, when we need to look at variables and analyze data, we really try and limit the variables so we have less scatter. And in that, what we do is we take away our sample sizes, we take away our patients, and then we end up with very small sample sizes. And then we say, well, it's not meaningful because we don't have a large sample. And so I think, artificial intelligence is really going to help us. But to do that, even when I started building the platform with a bunch of biomedical engineering students, then we had to go back and say, actually, where's the evidence? So I really want to give credit to one of my students who's done an amazing amount of work through a grant that we got from ASONS in doing a large systematic review to look at all of the literature in machine learning and Menieres disease, and look at what's the most minimum amount of data that you need that's robust. And, what he found is you can have, 90 data points and you can have 4 data points. And if you look at the blue, it gives you still as robust a data. And what is really important about this for us in terms of being able to scale it is that, if you minimize the amount of data points you need, it means more patients can use it and more patients can use it on a robust method. So the next stage for us is, our society, ASONS, has funded a national database, and that database was actually designed for otology patients. And so the next stage for us is to build a platform using these data points that we've identified, build a platform on the national database so ENT surgeons can, input their patient data on that, and then that is the platform for us to develop more research. So hopefully that sort of helps understand that you can helps explain that you can do research, but if you don't have the right infrastructure available, you end up with poor quality research that doesn't have a lot of meaning and doesn't really help all categories of patients. Here's, another student of mine also working on the hearing aspect of this as well. So, working with some clinicians in the Artificial Intelligence Institute in Deakin, looking at outcomes of cochlear implants, and particularly also looking at Menieres patients. And the ideal of this, his output of this will be eventually to develop an app where you can put in all of the variables of the patient, such as age, other diseases, duration of hearing loss, cause of hearing loss, all of those factors, and preoperatively be able to predict what their cochlear implant outcome is. So, we've sort of looked at the Menieres patients and gone, well, in general, Menieres patients have, good outcome, but, that's only a sample size of about 35 patients. But what we want to do is say with certainty to patients who may have numerous other cofactors and other complicated otological history, to say, well, we've now studied 2,000 patients, and based on that, with these variables that we put in, your outcome will be such and such. So these are all sort of ongoing work, but I'll sort of stop there and maybe just open the floor for discussion, because I realize that that's a lot of data that I've put to you guys.
Unmute. Hi, Anita here. We've had a few questions. Some of the questions I think you've covered. They were asking about the recent research advances, understanding the causes of Menieres. Oops. Just put my video on again, sorry. And with the recent more recent changes in research, I think you've covered most of that. Did you want to say anything else about anything related to causes, or it's just like what you mentioned earlier in your slideshows?
Look, I think it's hard to sort of say anymore, only because what I try to do is try to find the cause for the patient, and there are sometimes a few variables. I mean, I think the patient group that I find really the most difficult to manage are the patients that have predominantly fluctuating hearing loss. They have fantastic dietary control. They have fantastic, they don't have a lot of stress, but their hearing really fluctuates. And often this group of patients tend to be young women. And, when I've sort of looked at their immune markers, sometimes they may have an autoimmune aspect as well. They don't classify, they do have Menieres disease because they have had vertigo. And, it's the literature is, it's recognized in the literature that this can happen, but often, this is such a small group of patients that they usually, I manage them with an immunologist. Normally I would send them to that and trial So this is sort of looking the spectrum of, like, look, we look at viral causes, we look at autoimmune causes, we look at salt restriction, we look at stress and all of those aspects. And there's also, of course, vestibular psychology. Sorry, I didn't mention that. I should have put that in the rehab arm. So all of those aspects are really important, and you just have to spend a lot of time with the patient to work out what is their trigger factor, what are they behaving, and then sometimes it just takes time to say, well, we tried this, didn't work, let's try that, didn't work, then let's try this, and eventually you do collaboratively work towards and get to a situation that works. You
spoke quickly about the COVID and seeing Menieres patients coming in with like vertigo happening because of COVID. Somebody's asked, have you seen increases in patients being referred to you due to COVID? Is there a possibility that coronavirus can also be a cause of Menieres disease?
So that's, these are really interesting questions. Even the question of vaccination and what does that do for Menieres disease. My my comment on that would be purely anecdotal. So I've seen patients who presented to me with exacerbated Menieres during COVID, not due to COVID, but due to the stress of the surrounding, isolation, moving houses with no support, running a business and letting go of patients, that sort of, the immense psychological stress that society has undergone as a result of COVID, but not, due to infection with COVID. I suppose because the community prevalence of COVID has been poor until recently, I haven't started to see a flood of patients infected with COVID that have developed Menieres disease. And the other thing is also, during last year, I had a lot of patients present with concern about vaccinations and COVID. And I really thought that, look, this is going to be a huge immune stimulant. We're going to see a peak in Menieres presentation. But I must say, I haven't seen that. So that's really positive, and it must hopefully give certainty to patients. It's surprising. I mean, I know that with some vaccines, there's been reports of sudden central neural hearing loss or, other factors, which often has been temporary. But definitely with Menieres, I've actually not seen a whole lot of Menieres.
That's good to know, reassuring, especially with the boosters and all that.
Yeah.
Sorry, Scott has asked, he's bilateral with terrible symptoms. Sorry, I have to organize this. In both ears, are his options limited? And also, like, he suffered injuries to both ears from explosion and high pressure water blast into his ear, which required surgical intervention to rebuild his ear. Can these injuries cause Menieres?
So in terms of the first question, are the options limited? The short answer is yes, but the long answer is really it needs to be targeted towards each ear. It's I must say, rather than limited, it's complex. The hearing solutions, having cochlear implants in both ears, sure, we can. But the problem for him, for Scott, is that you can't. What's the end? The end strategy in terms of uncontrollable Menieres, and that's a labyrinthectomy. But deafferenting both sides is a pretty terrible thing to do, and can cause pretty severe vestibular impairment, especially if there's already arthritis and a bit of cataract disease and things like that. So it's not something people like to consider, because it can cause quite significant impairment and disability. So with respect to that, you're really cautious in terms of any ablative strategies. And that's kind of, then you go, okay, it's limited in the sense that you don't want to look at ablation for both sides. Although I've certainly had patients who I've ablated on one side and then they've developed Menieres disease on the other side later on. And you just have to be very careful that you can't do that for them. You can't ablate the second side for them. As far as then one of the that study that we did, where we looked at cochlear implants, in bilateral cochlear implants and patients with bilateral Menieres disease, I think I'm very cautious that I would, only because we want to, not take any risk to deafferent both sides. We found retrospectively that, you need one patient to have a bad outcome to then view your view. So in my opinion, in my hands, I wouldn't offer bilateral cochlear implants to a patient with bilateral Menieres disease, only off the very, theoretical risk that the cochlear implant may cause some vestibular damage. We've not found that. There's lots of studies done in cochlear implantation with vestibular disease and and vestibular, insult, and we found that it actually is very safe. But with Menieres patients, you already have a very irritative, fragile vestibular system. So just as if you've got one good functioning ear from a hearing stage and one really poor balance functioning ear, you always prioritize the balance function than the hearing function. That's sort of been my strategy. As far as the next question, can the previous injuries cause Menieres disease? I suppose it's difficult for me to explain or answer that question without knowing if he's had any inner ear injury or whether it's been largely middle ear injury. So if he's trauma had caused middle ear injury, I'd say that it's unlikely that that caused, Menieres. But if he has had any inner ear injury, it's going to be, I think it's difficult to say whether, secondary hydrops has not occurred due to underlying inner ear trauma earlier on.
Okay. Sorry, I'm just, Regina has asked, are there any strategies for reducing tinnitus that you can recommend?
I think the most sturdy, so often I really like something that Selene used to say, is that the tinnitus is often, in Menieres disease, is often, your friend, in the sense that it's alerting you to a fact that you may develop an attack, so to listen to the tinnitus. But of course, it's a very bothersome symptom to have. The most constructive thing you can do with tinnitus is address your hearing loss. Because if you do address so there are numerous factors that go into, tinnitus. Tinnitus can be because you're developing hearing loss, but, patients with good hearing loss who have, high anxiety or grind their teeth or, have a huge caffeine drive, all of those factors can also cause tinnitus. In the setting of Menieres disease, you think the tinnitus is actually being caused by active Menieres disease, but again, you've got to work with the patient to see what other cofactors they have that may be causing their tinnitus as well. And it's important to address all of those things to target the tinnitus. But the simplest thing you can do for Menieres disease with tinnitus is, aid your hearing. And if, your hearing's not aidable, then, consider a cochlear implant.
Okay. Andrew has asked, he's been told that he shouldn't consider the endolymphatic sac or clipping surgery, as the scarring that develops over time can make a cochlear implant, if needed later on, impossible or less effective.
So
your view?
I think everyone has their own particular view. In my hands, what I normally do is do decompression rather than destruction of the endolymphatic sac. And that's only because then you've not injured the inner ear. It's difficult to say even in endolymphatic sac ablation, whether that would necessarily cause inner ear damage. We would, there's always that slight risk that, the more rough you are with the endolymphatic sac, you could cause permanent hearing loss. And in that situation, you do worry if there's a, inflammatory condition happening in the inner ear and the cochlea can get scarred. But if that was the case, then, the option would be to fast track do a cochlear implantation rather than delay. So the longer you wait, the more the chance of the inner ear to completely ossify. But certainly how much scarring occurs is highly variable. And I certainly, wouldn't have thought that endolymphatic sac decompression would cause a lot of scarring. So perhaps, they're sort of avenues to look at depending on what you do to the endolymphatic sac or what the clinician had planned for the endolymphatic sac. But the other thing is also, if there's other strategies, other non-surgical strategies to undertake for Andrew, then, again, to explore that first as well.
Scott's come back.
We've got time for one more question, okay?
I've got one quick one. Scott's come back and said it was an inner ear injury. And then...
Yes, sure. Look, it's hard to be definite, but it's, of course, entirely possible.
Yeah.
One more. Okay, one more.
Last question. No, yes, no?
Yes, sure.
Yes, please.
Yeah. Sorry, who is this? Sally Edsels asked, like Gary, what do you think about the viral causes like Epstein-Barr, which stays dormant for a long time? She's noticed one study saying that having Epstein-Barr is a risk factor for long COVID, and some long COVID symptoms are similar to Menieres, oral fullness, imbalance, etc.
Look, so there's definitely some patients have a viral cause. I've been particularly interested in this area for a while, and we've had a study running, and I think we're finally COVID's really played havoc with that study in terms of our data collection, but we've sort of said that we're just going to go ahead and just look at the samples anyway. And that was particularly looking at herpes viruses, and EBV is a type of herpes virus. But as a clinician, you know, rather than keeping my patients waiting, when I test them, just for me to understand what their cofactors are, I will very commonly do viral serology for herpes anyway, and I would normally do HSV, so herpes varicella zoster, EBV and CMV, which are the common herpes viruses that have been associated with it. And I must say, in all of the patients that I've tested, I've only seen 2 patients that have been positive, but not for EBV, only for CMV. And we know that CMV can cause fluctuating hearing loss as well. So that's what I have seen. But again, you know, it's you never say never and never say always, but until now, I've not really seen a great relationship with EBV. Zoster has been, you know, reported in the literature, and as has herpes, but in the last 2 years, whilst been interested in the virus space, I've certainly noticed more CMV related presentations.
Thank you so much, Professor Mukherjee, for your insights tonight and your knowledge. Thank you.
Yeah, thank you, Professor. Really, thank you, Payal. It was wonderful, very informative. Yeah, great.
Thank you for bearing with me so late in the evening.
No, it's great. Really, it was. We'll be recording this, everyone. So if you want to rewatch it, it'll be up tomorrow probably. Okay. Okay. Good night. Thanks, ladies. Thank you. Good night.
Thank you.
Good night.
Good night, everyone.